There are a couple of ways to do this talk, and one is to do it really calmly and do 4 or 5 articles and really teach it well and show you a lot of data points and really delve into the study. So I'm not going to do that. And what I'm going to do is try to talk about a lot of different articles. 100% of the slides and more appear on our emergency medicine website at Vanderbilt. So if you want the information, every single slide and more, if you just Google my name, I'm at Vanderbilt, and the Vanderbilt website has all of these talks, this talk on Monday morning. So the first thing I want to talk about is something that we're called upon to do all the time, and that is resuscitate patients, most of whom have arrested in the field. And about a year and a half ago, at the very end of 2015, the ACLS new recommendations came out, and a really crazy statement. I'll stay over here because I can't do that. It's too early to wake up. And what the authors suggested in the new ACLS book is maybe antiarrhythmics didn't make that big of a deal. And so this New England Journal article is a really important article. And what it says is as follows. In a comparison of amiodarone, lidocaine, and placebo, they were very hard-pressed to show a significant difference. This is a randomized, placebo-controlled trial. And that's really unusual in ACLS. I'm going to do it from here so I don't have to worry about the microphones. When they compared the 3 drugs, there was no statistically significant difference, though there was a trend towards amiodarone being a little bit better. And here are the differences, and none of them were statistically significant. There have now been 2 additional publications that have summarized the literature. This one appeared in Resuscitation, the next one in the Annals, still in press. And what it says is as follows. In comparing amiodarone to lidocaine to placebo in at-a-hospital arrest, there is no statistically significant difference, and it's unclear that the antiarrhythmics really even work when you look at discharged alive or discharged alive neurologically intact. Now, the authors of the original study have pointed out that if you witness the arrest, amio and lidocaine make a difference. If you witness the arrest, at least to getting the patient back and potentially getting them out of the hospital. But for the arrests that come in to us from EMS, it's not that important, and what we're learning is the only things that make a real difference is early defibrillation, high quality CPR, 100 to 120, 2 inches, minimize the interruptions. Be sure the time to shock and get back on the chest is short. And here's from the Annals a summary that says it doesn't matter. I really like this next study. This next study compares amiodarone to procainamide in wide complex tachycardia. And how many use amio? And how many use procainamide? So procainamide is a drug from the old days. It shouldn't work that well, but it does. Please take a look at this graph. This compares procainamide to amiodarone, and as you can see from here, procainamide is double the efficacy. Double the efficacy. And I was really surprised by this. Now, hypotension was common with both drugs, and a lot of the amio patients required immediate cardioversion. But the adverse effects were double with amio. To me, I no longer want to use amiodarone. I think procainamide is the way to go. And I thought I had a laser pointer, but I don't. So this is my approach. Wide complex tachycardia. Be sure it's regular. And I'll tell you, there are a lot of really fast atrial fibs that look regular. Be sure it's regular. I like trying the modified vagal maneuver. I'll demonstrate that in a minute. I push adenosine 12. It either works or it doesn't. And the reason I push adenosine is about 15% of wide complex monomorphic tachycardias are not VTach, but they're supraventricular. Then go with procainamide. And the way you can give it at 35 to 50 a minute. My personal bias is to go ahead and give 100 in the first minute, give another 100 the next minute, and then go 50 for another 3 to 4 minutes. Get a couple of 100 milligrams on board. It is so damn good. The only time I would not use procainamide is in either a hypotensive patient or someone that has a prolonged QT. Like if you know it's a patient's had torsades 3 times, run away from procainamide. In fact, I would run away from the patient and just give MAG. The bestest way to treat a wide complex monomorphic tachycardia is to shock it. However, in really stable people, I really think you ought to try a little bit more, and I believe in 5 steps or 5 causes, and those are my 5. Please be sure it's regular. Okay. Ooh, now I have a pointer. Okay. This is a key article, and this tells us what we're doing might be wrong. So in 1962, Redding and Pearson showed that epinephrine was really good in VFib. And so if a drug is good, give more of it and give it sooner. So in the current ACLS recommendations for ventricular fibrillation, it's shock as soon as you can, start pumping, shock, 2 minutes CPR, and shock again. And my bias is in the first 2 minutes, just put on an oxygen mask. Don't focus on the airway. Focus on high-quality CPR and shocking. Well, this is a study from Get With The Guidelines. And this is 3,000 patients treated in our hospitals. And what they did is they looked in VFib, when was epinephrine given? Shock, 2 minutes of CPR, shock, now you can give epi. Or for some people, they were giving it sooner. About half these people got it sooner. Shock, CPR, let's go ahead and give the epi, shock again. So this compares epi before the second shock and after the second shock. ROSC, survival, and good neuro. Each one of these was, as we say in the business, worser if epinephrine was given sooner. Do not give epinephrine before the second shock. Shock, 2 minutes high-quality CPR. Shock, now you can consider it or give epinephrine. When you look at return of spontaneous circulation, when you look at survival, when you look at good neuro, each one is statistically less if epinephrine is given sooner. Be careful. Wait for the second shock. And in parentheses, Fiona Moore in England right now is doing a randomized, double-blind, placebo-controlled trial of nothing versus epi in VFib, asystole, and PEA. They're going to do 7,000 patients, and then we'll know. There are 2 drugs I want to comment on very, very briefly. Narcan, or naloxone, and glucose in cardiac arrest. This is an interesting study, and it's out of Rhode Island, and they look at confirmed deaths from narcotic overdose. And what they found was that when they looked at these 124 deaths, in about a third of them, no Narcan was ever given. Now, this is at a hospital cardiac arrest, but the point I want to make is that there are some respiratory arrests, PEA arrests, that get intubated, that get ventilated, that may go to the ICU. Narcan has no downside other than reversing narcosis in general. I know it can cause withdrawal. Please, if you have someone that's a PEA arrest, could this have been a narcotic overdose? There is much loss of face, trust me, I know, in people that go to the ICU intubated and they say, hey, Did you all not even consider Narcan? We woke her right up. The people that we miss are as follows. Older patients, they couldn't use narcotics. Women, and if they had no visible track marks, and they looked like us. So, be careful. And this is what I think. If you have a respiratory arrest, just be thinking, let's squeeze some Narcan. Now, obviously, if someone is very dead, it doesn't matter if you give them Narcan or not. And then the other point I want to make is as follows. Glucose is a great drug for hypoglycemia. It sucks in cardiac arrest, not due to hypoglycemia. This was shown in the 70s out of the Seattle data. But this is now 100,000 patients get with the guidelines. They looked at D50 or no D50. Decreased survival, decreased neurologic outcomes, no benefits, and it's dangerous. It's hyperosmolar. As Ms. Reagan said to us, just say no. Check their glucose, but don't give it if they don't need it. The article that I'm not going to talk about, other than to say this is one of the bestest articles ever, appears in the Annals this past year. And it is a summary of everything. So if you don't know anything and you want to know everything, or at least quote an article that does, and just say something dismissive to your partners, you didn't read the Annals article? It's an amazing summary. This article has like 99 references. Yeah, it does, 99 references, and it really gives great guidance. And it talks about what works and what doesn't. And so let me summarize. Nothing works, okay? This is a really well-referenced article to say that very little works. And it goes through lots of stuff. It really is a great, great article. It does mention ECMO and ECLS, and I don't want to delve too much into it, but I do want to make the point that more and more centers are doing ECMO. More and more centers are taking patients either from the ED or cath lab and putting them on ECMO, and you ought to be facile with at least its indications, which I'm going to cover. This is looking at survival. This is all of the ECMO articles from all of the ECMO consortium. It's from like 1,800 patients, more than 50 countries, and they looked at ECMO over time. It's gone up about tenfold. So we're doing it more and more. It costs between $50,000 and $500,000 to do, depending on your hospital and billing system and what else is bundled in. But look at survival. There's been no statistically significant increase in survival. And part of that is more and more patients that are sicker and sicker are getting it. But I think what you want to know is who should get it. And so I apologize. I have a summary slide, but it does not appear. The people that you want to consider ECMO in are as follows. The person had a shockable rhythm, VFib or pulsus VTAC. It was presumed cardiac. It was witnessed. They did not have a long time of compressions until you can get them on mechanical CPR and get them into the ECMO unit. So you can't like do 3 hours of CPR and consider ECMO. These are witnessed. They get CPR and they quickly go on ECMO. In those people who are taken to the cath lab, they do better. And there is, in fact, a director of EMS, professor of cardiology and emergency medicine who arrested and died and told his ambulance service, take me to my medical center. I think I'm having a massive PE. He arrested. He went on ECMO. He had a massive PE. They pulled it out of him. He stayed on the pump for a day. And I think he's a little bit balder in the back, and it annoys him when I say that, but he is 100% normal. And he would be dead without ECMO, because you can't have manual CPR for an hour or two while you're having your clot removed. I love this article. It has great algorithms for PEA, talks about ultrasound. Use this article. All right, so let me present your patient. A 38-year-old woman is being treated for a calf DVT, and she comes to your emergency department with shortness of breath, tachypnea, pleuritic chest pain, S1Q3 on the ECG, and she arrests in pulsus electrical activity. I'm aware that there are 5 causes, 5 steps, 5 reasons. My question to you is, should you give lytics? Are they proven? Not my opinion. Are they proven to work? And there's great controversy. Be aware of this article. Is TPA effective in PEA arrests due to massive PE? 23 patients, most out of the emergency room. Many of them had had a spiral CT, were going to be admitted. Some of them had not, but they were presumed to be PEA. The literature on lytics in cardiac arrest, lytics don't work in all cardiac arrest. So if you randomize patients, lytics versus no lytics, and they're just not selected carefully, there's no benefit to lytics. This is different. In someone that you think has a PE or does have a PE, if they arrest, should you give thrombolytics? And they gave 50 IV of TPA over a little bit less than a minute. So normal TPA dose in MI, when we used to give it a lot, was 100. This is 50. This is the same dose that was used, the half dose that we used in the Moffitt trial for PE. It had no hemorrhage, no side effect. So 22 out of 23. 22 out of 23 got a pulse back in between 2 and 15 minutes. But the most impressive thing is as follows. 20 out of 23 are alive 2 years later. And so this article says to me clearly, when you have a cardiac arrest that's due to, or you think it might be due to a pulmonary embolus, you're comparing a survival rate of 2 to 4% in PEA to greater than 50, and here close to 90% with thrombolytics. Janis Joplin many years ago said that freedom was just another word for nothing left to lose. If you have a person in cardiac arrest with PEA and you don't get them back with oxygen and they don't have a tension pneumothorax or hyper-K, in general, they're going to die. Using TPA, if you think it's a PEA arrest due to a pulmonary embolus, giddy up. Now, this article says one thing. If you don't intubate kids all the time, bag them. And so this is 2,200 patients, 1,500 of which get intubated. This is, again, get with the guidelines. It's a national consortium of hospitals. The median age of these children are 7 months. They use matched intubated and non-intubated patients. And this is what they found. When they looked at survival, and when they looked at survival if the child had a pulse when they were intubated or they had no pulse, they looked at intact neurologic survival. What they found was survival was better with no intubation. If the person had a pulse, it was significantly better. And if they didn't have a pulse, it was still better. If you have a child who arrests, early on, oxygenate them and ventilate them. Most pediatric arrests are respiratory. We ought to be able to bag them well. As things stabilize, do your intubation. But trying to intubate a hypoxic kid and letting he or she get more hypoxic is more likely to cause harm than good. This study says, and most of these intubations were done by pediatric intensivists, pediatric code teams, and the Peds EDs, and in some general EDs. Be careful. And just published in JAMA is a similar study about adults, and it says the adults that were intubated did worser than the adults that were initially ventilated. What the real take-home of the adult hospital data is early shock and shocking 2 minutes, high-quality CPR is the key, and dicking around with a bunch of drugs and intubating if you don't have everything stabilized is wrong. Now look, I've been doing this since we used beryllium. I've memorized 19 different ACLS protocols. I started out using calcium, bicarb, glucose, atropine, and epi, and we would talk about the exact sequence. It's all a waste of time. There are 5 causes, 5 steps, 5 reasons for everything. 100 to 120. And just, I don't know if I'm being taped. If I'm not being taped, what really pisses me off is there's an article just coming out that says maybe 130. But anyway, 100 to 120. 2 inches. Full recoil. Minimize interruptions. Do not hyperventilate. Ventilate every 6 seconds. If you do those 5 things and shock every 2 minutes, you are going to save a life. And if you do all the other crap, you're going to look really good, but your survival of the patients will be much less. We need some new drugs in cardiac arrest because pretty soon you don't have to memorize anything. And I don't know what the ACLS book, they're going to give you just the card. It's the card, it's the course, and you flip it over and you sign it and you're certified. If any of the AHA people are here, I did not say that. My videos don't play, and so let me just talk to you. Number 1, you can pump on people if you wear gloves. It is unlikely that you'll feel anything. If you're a real wimp, wear 2 pair of gloves. Or, if you work in an institution like I do, tell the resident, keep your hands there, don't worry. I apologize. Some of my residents are here. They know what I'm telling them is true. So I want to talk against the Valsalva, and then I want to talk for it. So this is the 5-step approach that I believe we should do in patients that don't have vascular disease, that are stable with PSVT. Valsalva, carotid, both, consider ice water, 12 of adenosine. 12 is better than 6, has no increased side effects. And I teach this, and, I'm pretty happy about it, and I got slides and everything. But between me and you, the Valsalva is a waste of time. It works 5 to 10% of the time. Don't do it. So this article, which I've presented in the past, and it's the only article I'm doing a repeat on, is a practice-changing article. If you don't do this, you should. Can you come up here? You, sir, right there. I don't have a video, but I do have a resident, and he's going to be a fellow, so he has to do what I'm saying. Can I trouble you to lay down? All right. In the past, what we would do is we would have a patient, they're sitting up in the stretcher, and we say, bear down, bear down, bear down, 5 seconds, done. It didn't work. So what this group did is they said, what about if we minimize sympathetic tone? If we had the patient bear down for 15 seconds or actually blow into a syringe, make the plunger move, that would give them an interthoracic pressure of about minus 40. It would block venous return. Then we have him stop. We lay him back, and to maximize venous return, elevate his legs. Does laying the patient back after Valsalva and elevating his or her legs make a difference? They're sitting on the stretcher, Valsalva 15 seconds, lie flat, lift, and then just return to the seated position. So that's standard, and they did it. I'm telling you 5 to 10%. They got 15% because they did it for 15 seconds. So, Jeff, I apologize if we could demonstrate because I don't have a video, but you're even better. So, Jeff has done Valsalva now for 15 seconds. There's a nurse behind him. The nurse lays him back, and as lays him back, we elevate the legs 15 seconds. Thank you very much. I just wanted to, so that I could show it better than see it. Lie him back, legs up. Let me show you what that does. 47%, and 2% of those people had atrial fib or flutter. They were, and one in sinus tach. When you get rid of the people that weren't in PSVT, it's 1 out of 2 responds to this. This is a dramatic, free, practice-changing article, no drugs, 15 seconds of your time. It's great, it's free, it's easy. We have converted to this in both Nashville Fire and in the ED, a precipitous improvement. How many of you have been doing this? Okay. Now, of course, all of you will do it. Think of me as your friend, a friend who's always right. So what I do is I say that to the interns when they're first starting and they giggle. If they want to graduate, they have to say, oh, yes. All right. I want to talk about MI now. Nitroglycerin and MI. So this is one of the stupidest studies ever done. As you know, there are 5 indications not to give nitroglycerin. One of them is an inferior MI. 1/3 have right ventricular infarcts. Giving nitro in an inferior MI is the mark of an amateur. And any one of you that does it should be arrested. So these Canadians, you know, I don't want to get like Trump, but you know how the foreigners are. So this is a Canadian study. Take it for what it's worth. And I do want to say that as any proud American, I hate all foreigners, but I especially hate the Canadians. And let me tell you why. They sneak in, you don't know they're Canadian, and then all of a sudden they go, eh? And then we got to throw them out again, all right? And I don't know how many of you have been to Canada. I don't want to put down another country, but now we're supposed to. You go there. They don't carry guns. And there's like people walking at night smiling. What kind of place is that? All right, but I digress. This is a study out of Montreal. It is a spectacular study. And what they did is they looked at the incidence of nitroglycerin-induced hypotension. And what they found is, of course, almost 1 in 10, 8.2%, had blood pressure go down below 90. And if they looked at systolic falls at 30, they had a quarter of them. I don't know why they did the study. But they had another group. And that was people with non-inferior MIs. It is the same exact incidence. Be careful with nitroglycerin in inferior MIs. Be careful in any other MI. It causes hypotension regardless of the type of MI. Be careful. Now, this is a follow-up study. This is a variation on it. Rather than looking at the type of MI, they looked at the incidence of hypotension based on vital signs. 10,000 patients. And they looked to see whether the patient was tachycardic or not. And what they found was very interesting, at least to me. About 3% of people got hypotensive if they had a normal heart rate. But 1/3 more got hypotensive if they were tachycardic. So be careful with nitro, especially if patients are tachycardic. And the lower their blood pressure is towards normal, the worse they do. So the take-home is nitroglycerin can cause hypotension. The more borderline the patient's blood pressure is, the more at risk they are. The more borderline their pressure is and tachycardic, those are the people for sure that are going to get hypotensive. Be careful. Be prepared to get their legs up. Be prepared to have them spit out the nitro or dial down the drip. Just be ready. Tachycardia and borderline blood pressure. So do you all know the best medicine for chest pain if you're not going to give nitro or nitro hasn't worked? I've traditionally used morphine. Morphine's a great drug. But be aware that morphine releases histamine. It can cause hypotension. It can cause nausea. In one study that I presented here 2 years ago, I showed that Plavix didn't work as well because people were vomiting it up if they got morphine. So this is a double-blind trial of fentanyl versus morphine. And people got one of these two drugs, either 5 of morphine or 50 of fentanyl, titrated in after they had nitroglycerin-resistant chest pain during ischemia infarct. And there was no difference in pain relief. More people got nauseated with morphine. More people vomited with morphine. And hypotension was seen with morphine, but not fentanyl. Based on this and other studies, I personally believe, and many centers have converted to our EMS system and many around the country, we've stopped using morphine and we give fentanyl now. It works. It has the same pain effects, decrement in pain, titrated in, much less nausea, much less vomiting, and especially in people you don't want to get hypotensive, MI patients, much less hypotension. I personally believe that we should take all VFVT arrests to cardiac catheterization, even if they do not have ST elevation on their EKG. There are a number of studies. This is a meta-analysis that appears in the journal Resuscitation this past year. 3,000 patients, 11 articles. And for those of you that are looking at the slides, 2,885 patients. And what they did is they looked to see if the person had a STEMI in the cath lab, a acute balloonable lesion. And not 100%, but 3/4 of people, if they have an ST elevation MI, with a cardiac arrest, they're going to have a stentable lesion. 1/3 of people without a STEMI have the same thing. If you have a STEMI and you go to the lab, you're more likely to leave the hospital normal. You're more likely to leave the hospital. You're more likely to leave the hospital with a normal or near normal ejection fraction and not chronic heart failure. It is wrong not to take sudden death patients with VFib, VTAC, who don't have significant underlying disease. It is wrong not to take them to the lab. About 1/3 of them, in multiple studies, are going to have an acutely balloonable, stentable lesion. They didn't fibrillate for the hell of it. You're just not seeing it on the EKG. And it dramatically improves survival in a statistically significant way. These are not randomized, double-blind, placebo-controlled trials. These are multiple observational studies. University of Arizona, Vanderbilt, many other big centers have done it. And I want to tell you, in my own center, there are some cardiologists that believe it's heresy to just take everyone to the lab because they have a VFib arrest. And we're one of the centers that did one of the best studies on it. All right, so which is better? And don't yell at me. Etomidate or ketamine? What I've heard in my own institution is if you give Etomidate, you're an idiot. And let me tell you why. Etomidate is a bad drug for RSI. It causes adrenal suppression, and thousands, entire villages have been wiped out when Etomidate has been used. And it's because a disgruntled ICU fellow left, and he and someone else wrote this article, and everyone knows that Etomidate sucks. And so we were using Etomidate. My father used Etomidate. His father before him at Vanderbilt used Etomidate. For those of you that know about the Pilgrims, they brought over Etomidate. And so I had never used it before I got to Vandy in the early 90s. I would carry Etomidate. I'd use it myself. I had amazing sleeps. So we did a study, and when I say we, people I work with. But when you're up here, you say, we did a study. So we did it, but my name's not on the paper. But on one of the patients, I gave one of those drugs, I'm sure of it. But anyway, a number of our people in the ICU, the trauma unit, and in the ED did a great study. They looked at 2 years of Etomidate before it was a bad drug. Then we switched to ketamine, and they looked at 2 more years. So this is a 4-year study, a before and after study. 2 years of Etomidate, 2 years of ketamine. It appears in the annals this year. And this is what we found. Or background, Etomidate, as I said, does adrenal suppression. Ketamine used to be in kids, now it's in adults. The problem with ketamine is it can cause hypotension acutely and adrenal suppression later. The problem with ketamine is it can elevate ICP, maybe cause tachycardia and sympathetic discharge. Neither is perfect. So this is an adult trauma center experience. And let me tell you what it shows. It shows that both are statistically equal with a trend towards Etomidate being better. We looked at everything. Penetrating, blunt, traumatic brain injury, GCS up, down, how high their injury severity score, whether they were hypotensive or not. There is no statistically significant difference in Etomidate versus ketamine. Both drugs are very good. Use one or the other as appropriate. Neither was statistically significant. And as far as adrenal suppression, we didn't measure it directly. But as far as the patient's survival or shock, ketamine group had a little bit lower odds of developing sepsis, but the Etomidate group had, if it was going to cause shock, it had lower number of days on pressors. Both drugs are good. This is my recommendation. If you have someone with borderline pressure, without doubt, ketamine is the best drug. If you have someone who you don't want to get tachycardic, who you don't want to spike ICP potentially, who you don't want a big sympathetic discharge, Etomidate is a better drug. Both drugs are excellent. We used to use Etomidate 20, unless they were really big, and then we give 30 or 40. We give ketamine 100 or 150. Know your drugs, but don't get hooked into, oh, you shouldn't give that. Give whatever you want. I want to talk about hypoxia. It's our enemy. I want to tell you that if you have traumatic brain injury, if you get hypotensive, your mortality will increase by 20%. If you're hypoxic, it will increase by 28%. And if you allow someone to get hypoxic and hypotensive, it goes to almost 50%. Be expert at RSI. Do not let people get hypotensive. Do not let them get hypoxic. And ketamine's a great drug, but it can cause respiratory arrests. Respect it. This is just 25 milligrams. I want to do one thing on airways, and then I want to talk a little bit about anaphylaxis and stop. When you're oxygenating someone, many of us have been taught, do a tight fit, put a bag valve mask on them, and if they're spontaneously breathing, hold it real tight and mash them. Even if they fight, just punch them. And so this study showed something very interesting. If you dial up your oxygen all the way, 40 to 50 psi, just dial up that boy or girl, or without sex, dial thing, or whatever gender identity the flow meter has at that moment in time. And it should be allowed to use either bathroom or both. Just dial it up and put a non-rebreather on. They do great. A non-rebreather is easy to wear. It's not as tight-fitting, but dial it up all the way. Supplement it with nasal prongs. I want to do one last disease and summarize. And the last disease I want to close on is anaphylaxis. And the reason I want to close on this is I want to say the following. We are not good as emergency care providers if we are not expert at anaphylaxis. And I think in emergency medicine, they're like one-word matches: VFib, shock; hyper-K, EKG; hypo-K, hypomag. If you give K, give mag. PEA, reversible. Anaphylaxis, epi. So I want to be very clear. Anaphylaxis, epi. The drug of choice by every publication, by every author, epi. So let me talk about anaphylaxis. How often do pediatric patients get epinephrine? There's been an EMS study, a pediatrician study, and an emergency study. They all show the same thing. This is 100 kids with anaphylaxis. One half of them get epi. No matter what, one of the people I trained with, John Dorsey, who had more than 100 publications, all of which have been retracted because most of them were fake, and it was a huge scandal because he made up data. His conclusions were correct, but he made up the data. If I were like him, what I'd do is I'd write up a huge series, and I'd say, and only in 49% of patients did they get epinephrine. Everyone would go, great article, this has to be true. Because every article has the same thing, 49, 50, 51. People do not give epinephrine. And when I say people, I mean us. People love Benadryl. And so here is an article that's coming out in Resuscitation. 3,000 allergy-related, and this is the last study I'm going to do, 3,000 allergy-related visits, 500 with anaphylaxis. About a quarter of them were over age 50. Older people, and older right now in my mind is about 88. Older people, and this one was 50. I don't know how I got to be this old. I was young like 3 years ago, and now it's appalling. Anyway, this is looking at the use of epi in Canadian hospitals and their related EMS service in British Columbia. Equal number of patients, both older, above 50, and below 50, that were hypotensive. If you were older, because they were more scareder, they gave mini-push IV epi. Most of the patients who had complications got IV push epi. The number one cause of death is the failure to give epi in anaphylaxis. And in a recent study in cardiac arrest due to anaphylaxis, which means severe anaphylaxis, 25% of people didn't even get epi until they arrested. That's how bad we are with giving epi. So anyway, what they found was this. If you were below age 50, this was like the highest number I ever saw. 60.8%, because I was going to fake the data and say 53. But anyway, 40%, 4 out of 10 people didn't get epi. This is confirmed anaphylaxis. If you were older than 50, because we're so afraid of epi, 1/3 of people got epi. The number one cause of death in anaphylaxis is the failure to give epi. So in 1/3 of people over age 50, we didn't give the epi. The older you were, the less likely you were to get it. Epinephrine is very, very safe. The dose is 0.3 IM. If you have an older patient and you're afraid to give epi 0.3 IM, then give 0.2 IM. The PD pen has 0.15, then give 0.15. Give epi. You can repeat it in 5 or 10 minutes. Give it IM. The thigh is better. So if you're so afraid, which I am too in a really older person, then give it in the deltoid. It will have slower absorption. IV epinephrine is for profound shock only when it's diluted and titrated in. There are 5 treatments of anaphylaxis: epi, H1 blocker, H2 blocker, steroids, and volume. But if the only thing you did was give epinephrine, 0.3 IM, if the only thing you did was give epinephrine 0.3 IM, you would be a pro ball player of whatever sport you like. All right. I want to do 2 sets of 5 summary points and get off the stage before you can ask questions and show that I really didn't know this stuff. Antiarrhythmics are of questionable value. Focus on high-quality CPR. You really need to know what improves outcome: early rapid defibrillation and high-quality compression. Do not give epinephrine and VFVT until the second shock has occurred. High-quality CPR, you can just do compression only, put a mask on, shock, 2 minutes of high-quality CPR, shock. Now start thinking about drugs. Nitroglycerin causes hypotension, most likely in those patients who are tachycardic and or who have borderline pressure. If you have someone with a blood pressure of 190 over 110, they're going to do pretty good probably. I love procainamide and VT. Amiodarone, if I weren't up here, I'd say amiodarone sucks, causes hypotension. I'm in academic emergency medicine. I'm not going to use those kind of words. Consider TPA in a cardiac arrest that is a pulseless electrical activity arrest in someone who has a legitimate risk or who does have a PE. Younger, healthier person, acute shortness of breath that's unexplained, and more likely she than he arrests, TPA 50 IV push. If you can't remember the dose, half-dose TPA. Somebody will know it. I believe strongly that if you have a patient who has a cardiac arrest, focus on oxygenation and ventilation until the scene stabilizes before you go for the airway. Don't be airway focused, be oxygen focused. I believe that all VFVT arrests need to go to the cardiac cath lab, irregardless, which is not a word, irregardless of whether they have a STEMI or not. Use Etomidate or Ketamine or learn them both. Don't get hooked into this argument. And our enemies in life are hypoxia and hypotension. No matter what you read, it's hypoxia and hypotension that are our enemies. I apologize, my slide isn't here. If you Google my name, it's Vanderbilt Emergency Medicine. This entire slideshow and about 50 more slides will be there Monday morning. Thank you all very, very much.